I would like to introduce our first speaker. We're starting, as we mean to go on, argumentative, entertaining. I give you Sir Muir Gray.
I'm going to tell you about the future.
You want me to?
Not because I have visions. Visions get you psychiatric referral or sainthood, neither of which I'm particularly interested in, but because, for two reasons. Firstly, the future is not like the Isle of Wight or Mount Everest waiting our arrival. The future is something we imagine, plan and build. You imagine, plan and build. If you don't do it, other people will. The second is that the future is here. It's just not evenly distributed. And what I'm going to tell you is some work that we're doing with Public Health England and other people about a new paradigm. Our paradigms, the word paradigm shift is very common, and there's a wonderful Tom Wolfe novel about real estate in Atlanta, where the chief executive is always talking about paradigm shifts until the hero of the novel tells him to shut up. But the paradigm shift, of course, was created by Thomas Kuhn in the structure of scientific revolutions. And the concept of paradigm shifting is something we've seen in all countries. Now, from 1948 in England and in the UK, there was only one important paradigm, and it's a paradigm that we have seen in every country apart from the United States in the last 50 years. And that paradigm was that healthcare was free. That was really all that mattered. Drug X or Operation X, it was free, it was available. Healthcare became a right and not a privilege. Then the paradigm shifted, and the key text was Archie Cochrane in terms of the effectiveness and efficiency, published in 1972. And we entered the era of the effectiveness paradigm, which morphed into the evidence-based paradigm. Evidence-based, I must tell you, when Ian Chalmers and I interviewed Dave Sackett in Toronto Airport, and he said he came to Oxford, and we were going to reproduce the Department of Clinical Epidemiology. And so we said, well, would you come and be Professor of Clinical Epidemiology? But then one of my principles is, and it picks up Fiona's principle, that there's no difference between irritation and stimulation apart from A, spelling, and B, irritation is more effective than stimulation. So we called it the Centre for Evidence-Based Medicine. And it sure as hell irritated people. And you may remember The Lancet had an editorial condemning these people in Oxford promoting evidence-based medicine because they've been doing it. So evidence-based medicine and effectiveness lasted until about the 1990s, until the financial pressures started to bite. And then we entered the paradigm changed, and thank you very much, Jake. The paradigm changed. The paradigm changed, and it's always very important to keep the audience alert. So the paradigm started to shift to become cost-effectiveness. So the question came, is X cost-effective? And then in 2001, the Institute of Medicine produced two landmark reports on quality and safety. And it's very interesting how much we owe to the United States. Someone said to me once, you just got to remember about the US, we have nothing as good as their best and nothing as bad as their worst. You know, there's fantastic things going on in the US. Actually, of my top 10 articles in Value, 8 of them come from JAMA and the New England Journal of Medicine. You know, the thinking is terrific. And the two reports on quality and safety led to the quality and safety paradigm, which has preoccupied us for the last 10 years. But for the next decade, and in my view for the remainder of the century, you can come back and tell me I'm wrong, in 60 years' time, the issue is value. This is the era of value. Now, what do we mean by the word value? Value is a very slippery word. English is a very slippery language. I met someone, Spanish person once, who was learning Japanese. I said, oh God, Japanese, that's difficult. He said, no, English is the hardest language in the world. Japanese is easy, because it changes all the time. So there's the two types of meaning for the word value. One is value in the plural, values. we value diversity, we value equity. That's one sort of moral meaning. But I'm speaking about the economic meaning of the word value. And again, there are two types of meaning there. The meaning from the individual's perspective and the meaning from the population perspective. There are, of course, many other meanings of the word value from different perspectives. The industry has a concept, return on investment. Hospital chief executives have a meaning. If you can get anyone over the threshold and get paid for it, it's of high value. I remember someone phoned me up once and said, are you screening for carotid artery narrowing? And I said, no, there's no evidence for that. Oh, damn, he said. I said, well, why is that? He said, well, we worked out, we could get a lot of referrals if we introduced it. And it was of high value because the money follows patients. But I'm going to focus on these two perspectives, the patient's perspective and the population perspective. And this is what I think of as the new paradigm. Personalised and population healthcare. Personalised and population healthcare. Now, the study of groups and randomised trials remains of vital importance. New paradigms don't necessarily displace previous paradigms, as I'll show you, but the preoccupations, I think, of the next 10, 20 years are on personalisation and populations. Now, let's take personalisation to start off with. This is when we were accused of cookbook medicine in the Lancet. We should maybe have used a picture. Wittgenstein said that every idea is a picture. And although there's a very good definition of evidence-based medicine published in a BMJ Leader, this picture might have been helpful. It's interesting, isn't it? Still, I don't think, have you had any pictures in editorials? Venn diagrams and arrow diagrams. But this was our picture for evidence-based decision-making. And of course, as it said in the tin, it was evidence-based. But there were two other factors that were important. One was the personalized condition of this patient. What are the risk factors they have? And of course, the weakness of the evidence. I think in heart failure, many of the trials are about people who only have heart failure, but only 3% of people who have heart failure have only heart failure. And that's the job of the human being, the clinician. And this is where Peter Rothwell from Oxford, I think he was the first to use the term personalised medicine, that how do you relate the evidence derived from groups to the individual? And still, human beings like yourselves are better than machines. Artificial intelligence has not delivered anything better than the GP for the morning surgery. I always say, how many of you are general practitioners in the audience? I always say the morning surgery in general practice is one of the intellectual marvels of medicine. And GP said, if you think that's a marvel, you should see me in the afternoon when I'm getting tired. That's a bloody marvel. So the speed at which human beings do this. Now, the other issue which is coming up, and which Peter may touch on too, is the values of the individual, the personalization of the values of the individual. And much of this I learned about from Al Mully and Jack Venberg and colleagues in Boston when we were arguing against PSA testing and looked at the evidence of treatment of prostate cancer. The values of the individual, the value-based treatment. And you see, I think we're moving in part of the new paradigm. So we're not just asking, did X achieve the result the evidence indicated? But the new paradigm, is your problem better, no better, or worse? Now, I've working with colleagues here in the last few years, I've had numerous run-ins with the surgeons. How many are surgeons here? Many surgeons in the room? Yep. About rates of elective surgery and knee replacement. So the sort of discussions I've been having were discussions on things like, we need more money for hip replacement. And I would say, well, yeah, but where did hip arthroscopy come from? You're using a lot of resources in hip arthroscopy. And hip replacement, and sure enough, as Carl pointed out, I think the Lancet voted hip replacement, not metal and metal, hip replacement the best operation of the 20th century. But you see, in the discussion, there's a chap, Andrew Price, who's the professor of orthopedics, one of the professors of orthopedics, and he said, well, what business are we in the Nuffield Department of Orthopedics? Are we in the knee replacement business, or the knee pain business, or the knee arthritis business? Or are we in the gardening business? I said, what do you mean the gardening business? He said, this woman came to see me, and he said, well, what can I do for you? And she said, I've come for a knee replacement. And I said, well, why do you want a knee replacement? She said, I love gardening, and I'm now having difficulty in bending. And he said, well, do you realize if I replace your knee, you won't be able to kneel at all? And she said, no, I didn't know that. Thank you very much, and out. So I don't know what she did, whether she raised the garden beds or what she did, but there were other solutions. And of course, as we see, we're going to, I think, sure hear about overdiagnosis. As we see more people, then the offer changes, and the values change. For example, cataract operation. Undoubtedly, evidence is that cataract is effective. But what we're seeing now is, as we increase the rates of cataract operation, we are, of course, seeing completely different types of people. 10, 15 years ago, people couldn't leave their homes, and we did a cataract operation. Nowadays, someone my age goes to the optometrist, and, oh, touch a cataract there. Referral, on the waiting list, operation. Any of you optometrists in the room? Ophthalmologists? Because if you were, these are Poundland. These cost £1. I don't go to get my eyes tested. I went. My wife said you must go for driving, so I went for driving. But I knew if I said, they would say, "Oh, what about reading specs? Would like reading?" I said, and if I'd had these, they'd have poo-pooed them, of course, with some sort of digital photography or something. So I left them in the office. I said, they said, "What about reading?" I said, "I've got good reading specs. Let's just test them." Oh, I've forgotten them. I don't. Because cataract operations go wrong 1 in 1,000 times. This has nothing to do with safety, and this isn't the best quality service, so the offer we're making to individual patients is different and depends upon their value. If, as many people in Oxford, if your job is studying medieval maps, then you might want the operation. It's a value decision. So that's personalised value, and that'll be covered in many other sessions. But I'm going to move on to population value. As you see, these two are interrelated because the amount of resources you put into something changes the offer to individuals. So firstly, allocative efficiency. So here's the position in England. Gastroenterology and liver disease, 4 billion. Respiratory, 5 billion. Cancer, 6.5 billion. Mental health? Let me get you to vote. I'm going to offer you 1 to 4 billion, 4 to 8 billion, or over 8 billion for expenditure. 1 to 4 billion, hands up. 4 to 8 billion, hands up. Over 8 billion? Yeah, it's 11 billion, not counting about 5 billion pounds worth of mental health problems that present as dizziness or abdominal pain. So there's about 16 billion pounds worth of activity. So that's the first issue, it's allocative efficiency. And policymakers have to make decisions about this. But what's emerging, and I'm very clear in this, I may be wrong, but I'm very clear, that clinicians will have to take the next stage, what we've called within program, between system marginal analysis. Who's going to decide how resources are allocated between bronchitis, sleep apnea, and asthma? It's just not possible for sort of policymakers, health boards to do it. They don't have the profound knowledge. A young chap I worked with in Bradford phoned me up and said they wanted more money for sleep apnea. And what will I do? I said, well, I'll tell you what to do. You get the asthma boys and girls and the COPD boys and girls, And the sleep apnea boys or girls in the room and lock the door. I spoke to him a week later. I said, how are you getting on? He said, oh, they're still in there. And I said, well, stop sending in food and water. You know, there is no more money. And even if there were more money, these are debates about value, about the balance of good to harm that we're doing. And I'm seeing now there's a group in Plymouth, and they've decided to take £2 million out of the asthma expenditure and put it into COPD. There's a lot of money being spent on expensive spacers, so they've decided to do that, to switch the resources. So this is a clinician responsibility. And probably the best term for this population responsibility is stewardship. Stewardship's not a word that translates very well, but comes from the environment, and it's an old-fashioned word in English. And, for example, the good steward of a farm leaves the farm in better condition than they find it. It's our responsibility to leave the health service in better condition than we find it. And if we carry on, lab tests going up 10% per annum, they don't cost anything, just sign it, send it off, that is going to destroy the health service. So it's stewardship of resources. So that's the allocative efficiency. Now let's move to the technical efficiency. And here, one of the jobs I've been doing is publishing what we call Jack Venberg tribute albums. I think it's covers, the young people call it. You know, I do covers for Jack Venberg. Jack, where are you? The Dartmouth Atlas of Healthcare. And we did these to destabilize the medical profession. These were done not as epidemiological, but as emotional interventions. So here's, this is knee ligament replacement, for example. To get people to think about what they're doing for populations. And actually, we could almost do these atlases by random number generators. I don't know if you've ever run random numbers across the US, Jack, but I mean, this is what we would get if we ran almost random number. Now, the technical efficiency is the relationship of outcomes to costs. And as you can see here, evidence-based medicine is still, of course, of vital importance. So outcome equals good outcome minus bad outcome. So that equals effectiveness, EBM plus quality minus harm, over costs. And costs could be money or time, because to clinicians, time is the scarcest resource, a finite resource, or carbon. And we set up a Centre for Sustainable Healthcare here. And interestingly, we find that frontline staff often respond better to discussions about sustainability than discussions about money. On the ward, if you say to staff, look, there's financial problems in this hospital, the staff say, of course there are financial problems. Look at the idiots who are running the place, who are usually standing beside me. But if you speak to them about sustainability, then you start to engage them about finite resources. Their children are concerned about the way we're using resources. So carbon has an important part to play. But even more important is this concept of the opportunity lost. If you want to spend money doing 400 endoscopies per million population, that's up to you. But if you also want a specialist nurse for inflammatory bowel disease, and other people seem to be getting on fine with 100 endoscopies per million population, that's your choice. But you better involve the patients in discussions about that. So here's questions that we cannot answer after 65 years of the NHS. We don't have a national health service. We have a national access service to general practice and certain rules about access. But we cannot answer simple questions like, is asthma care better in Somerset or Devon? You could substitute any disease in any country, and I've yet to find anyone able to answer these questions. But surely these are the key questions in value. It's about populations. Is asthma care better in Saskatchewan or Alberta? Is care for epilepsy better in Valencia or Lombardia? I don't know. But surely these are the questions. These are population-based questions. Not to do with institutional quality, but with population value. And the aim of population healthcare is to improve the health and well-being of individuals through population-based systems accountable to patients. So let me show you what they look like. This is our current problem in every country. So this is £6 billion, £11 billion, £70 billion, £20 billion. The occasional patient, I think there's one there, you see, you can swim across from place to place. But these are isolated islands. And we've introduced a thing called commissioning in England, And I can see 5 different types of, so if I take glaucoma, there's people in Leeds thinking about how you pay optometrists. There's 211 of those, 10 of those, 152 of those, and a screening program. Do they speak to one another? No. And if you even brought them together, they would just speak about their own bureaucracies. That's what the nature of these things are. So here's what a system looks like. It's like a Russian doll. And it's self-care is the most important type of care. Informal care, generalist care, specialist, and super specialist care. I wrote this actually in The Lancet in 1983 and said we should run all of healthcare on the basis of programs and systems with budgets. And we do know in England we spend £1 billion on asthma, so we've got some information. But we don't know to the nearest 100 million what we spend on epilepsy, although we need to the nearest pound what we spend every hospital and health centre. Yeah, I wrote this in 83, and I showed it to someone 2 years ago, and then I showed him the date. He said, 1983, God, you're clever, Muir, clever. So I rushed and showed it to someone else, and I showed him the date, and he said, 1983, what the fuck have you been doing for 28 years? The answer is waiting for the money to run out. You see, if you look at what medicine has done, I would say that we've only got systems for about 4 or 5 conditions. Cancer, end-stage renal failure, acute MI, and acute stroke. It's where big machinery has forced the medical profession to think systems. But most of healthcare is like Brownian motion. Acute chest pain works pretty well, although there's, in our atlas, we showed a 50% variation in stenting for STEMIs. So even a simple thing like that's not yet sorted. But if you've got breathlessness or heart failure, it's a random distribution across these different territories. So what we're looking at are what we've called quick wins and big messes. The quick wins would be something like atrial fibrillation and anticoagulation. Just sort it out. The big mess is something like headache or pelvic pain, where we have to describe what the system is. And about this stage, we ban the use of the words primary and secondary, acute and community, and say this is the new language of the 21st century. System, network, pathway. System, network, pathway. So here's what a system looks like. This is sickle cell disease, and quite a complex disorder. And it took a young doctor working with the patients groups about 4 years to do this, but everyone now knows what we're trying to do and what the measures are and what the standards are. Just to finish, to think a little bit about what are the implications for clinicians, particularly specialists. So here's an example of an excellent doctor. She's doing evidence-based medicine, patient-centered medicine, and every year she tries to improve the quality of the service she offers. But Dr. Jones, how many people are there in Derbyshire with COPD? The answer, about 4,000, of which she sees about 700. Then she does an audit, and she finds that there's about 400 who would really benefit from her service. So she asks for resources to expand her specialist service. But Dr. Jones, 2 things. Firstly, there's no more money. And secondly, we've banned the word outpatients. Outpatients were quite useful in the 19th century, but what do you mean outpatients? So what we'd like to do is to practice population medicine. And we'll pay you a day a week for this. Someone will still have to manage the respiratory service for the referred patients, but we want you to think about equity. For example, to look at referral patterns, to wonder why some children are being referred from some housing estates with asthma emergencies. These are the sort of questions that we would like you to ask, and we'd like you to write an annual report. If you don't have an annual report, you don't have a system. And what we're working at the moment on different sizes of population. For example, neurofibromatosis. There are 4 systems covering England. This wasn't done by the government or anyone. This was just people got together and did it. Teenage diabetes I'm working with, partly for personal reasons. And I think we're going to have 10 networks, each with about 175 nodes in the networks locally. Familial hypercholesterolemia, 12. End-stage renal failure, 27. Asthma, pretty common. Not much super specialist care, maybe 120. These are the sort of debates. They'll bear no relationship really to any bureaucratic boundaries. You have to have bureaucracies for the uncorrupt management of money and the open employment of staff, but that's all that they do. And of course, within that, there'll be within system margin analysis. You know, you guys will have to decide what's the best use of the spend. And the respiratory people, again, have shown the lead. They switch resources from triple drug therapy to smoking cessation and rehabilitation. Good stewardship of resources for the population. The 20th century was the century of the bureaucracy. Professor, consultant, GP. The 21st century is the century of the network. Professor, consultant, GP, pharmacist, nurse, patient. And of course, technology is changing culture, and this is the most, I don't think you had this in your photograph, Carol, did you? This is the radical technology. How many of you don't have a smartphone? Don't have a smartphone? Yeah, there's usually quite a lot of the middle class don't have smartphones. But I'll tell you three things. Firstly, poor people have smartphones. Secondly, poor people know how to use them. And thirdly, you're all going to have one. It's been decided. Game over. Not by the government or anything, but by, you know, O2 and Vodafone. This is the driver, and this is creates this. And this, you want to think of a model? It's the ant colony. Ants are complex adaptive systems. It's not a market, it's not a bureaucracy. They all have roles. I mean, the queen doesn't tell people what to do, she just lays eggs. When things go wrong, they change their roles a bit. And they make sacrifices. They don't all try and win and make their own department bigger or more important. The good of the colony is the driver. So the ants are the key thing for us to learn. Now we've got 2 minutes before the next speaker. So what I'd like you to do, just to wake you up, because the evidence is that what you say to your neighbour the next 2 minutes, you'll remember more than what I've said to you. I'd like you to reflect on the concept of population health care and think of one particular aspect in your own work. It could be a symptom, like headache, or a condition like rheumatoid arthritis, or a population group, like frail elderly people, where the principles of population health care would give more value to individuals and populations. Let's just take 2 minutes discussing. We don't think we've got time for feedback. I may pick on one person. 2 minutes to speak to your neighbour about population health care and some problem you're going to tackle when you go back after these 2 days. Okay, 2 minutes starting now. And he said two things. Firstly, they'll remember what they said to their neighbour. And secondly, the more senior they are, the more you shout at them. You know, if it's chief execs, you'll really lay into them and pick them out. You stop talking now. That's what the management consultants do, and pay a lot more than I would ever dare to charge. Anyone like to volunteer some issue they're going to pick on when they go home? If you don't volunteer, it doesn't matter. I just point because you've all been talking. Yep, just shout an hour.
So, rationalising pharmacological treatment in over 80s with multiple pathology.
Yes. The word frail elderly is very difficult, means so many things, but let's just take the over 80s on 4 medications, and you'll sure as hell find they'd all be much better, probably in 3.5, and there'd be cash release you could put into home care services. Very good. So people in multiple medication, that's a population group. Any symptom? People have burning symptoms we may hear about later on, but symptoms are a bigger mess than conditions. The biggest mess I've dealt with in the last few years has been pelvic pain. Yep, Peter. Low back pain. Yeah, low back pain. Well, you see there, I'm looking at ways which we would get some surgeons practicing population surgery. Even 1 day a week, they would be influencing GPs instead of just being at the end of this crazy referral pattern. Low back pain. And what's the worst? What's the best organized clinical service for a condition? Anyone like to guess? Stroke, childhood leukemia. I mean, every child, I think, is in maybe a couple of randomized trials. The guidelines are based on good evidence and it's personalized. What's the worst? Anyone like to? Probably epilepsy, inflammatory bowel disease would be high in my list of things that are just Brownian motion. Okay, thank you very much.